You've seen our research on social media. Now, join us as we dive deeper into the public health topics of our time, featuring new studies and findings generated by our faculty and researchers committed to advancing health equity. From the Department of Population and Public Health Sciences at Keck School of Medicine of USC, this is Preventive Pros, the podcast.
My name is Roksana Karim. I am an associate professor within the Population and Public Health Sciences Department at the Keck School of Medicine. My primary responsibility within the department includes both research and teaching. So I teach several core courses within the Masters of Public Health program for both the online and the in-person classes. I also teach a core class for the undergraduate students. My primary research interest is in women's health. In particular, I am interested in menopause and menopause-associated chronic inflammatory diseases in women, which includes cardiovascular disease, bone loss, and cognitive decline. In addition to menopause-related health outcomes, I have also have vast interest in HIV/AIDS and other sexually transmitted diseases. I was involved with the Women's Interagency HIV study, which is a national cohort study funded by NIH. And that has been, going on for 18 some years now. And I published heavily on immunopathogenesis of HIV, AIDS in women. And also I published on endocrine, metabolic, and cardiovascular effects of HIV and HIV medication in women. But today I'm going to focus on my work in menopause and menopause-associated health outcomes in women. So menopause is an inevitable event in every woman's life if we survive that long. And there are some adverse health effects of menopause in women's health. Primary symptoms or constellation of symptoms that women experience because of menopause, which is actually cessation of production of female sex hormones by the ovaries. And as a consequence, women feel extreme hot flushes that are disruptive of their day-to-day activity and productivity. And then night sweats, mood swing, and also memory-related issues also start to show up around that time. In addition to these quality of life issues, women also experience changes in their metabolic health, which actually eventually increases the risk of cardiovascular disease, as well as some of the other chronic inflammatory conditions such as osteoporosis or bone loss, and also decline in their cognitive skills. So looking at these changes in the women, in the key women around me, I grew up with my mother, my grandmothers, my aunts, and it obviously feels like it's not fair. And we need to do something about it. That was the response growing up. And when I went to medical school, I did learn the underlying mechanism of these changes in women's, reproductive health that comes with age. And like I said, it's inevitable. So that actually inspired me to focus on these. And then when I started my doctoral work, there is this very clear data showing the increased risk of atherosclerosis and cardiovascular disease in women right after menopause. So that inspired me to take a look at these issues at a molecular level involving the sex steroid hormones, particularly estradiol levels, and these metabolic markers and atherosclerotic changes in women. That's what I started out with. As a matter of fact, these issues have been in question and being looked at for a while. I mean, not just now. Where I grew up in Southeast Asia, Bangladesh. I mean, when I was in even med school, there was no concept of hormone therapy or availability of hormone therapy for the women in that part of the world. However, when I moved to the US in 1998, I do see the practice of hormone therapy in the Western women. But around that time, when I was starting with my doctoral work, there was this huge issue about huge study results reports coming out, which was like the study was terminated prematurely, and there were a lot of uproar about the reports from that study that women were experiencing adverse health effects like blood clots and stroke because they were put on hormone therapy, and that actually inspired me, even more to look at this. And you would think that a supplementation of estradiol would help you. And I started looking up the literature, and it does help you in all the observational study evidence point toward that it does help women, and the women have a much better quality of life and all the other parameters as well. However, that point on, the research started looking at things differently, and there were quite a few, major research coming as a consequence of that study, which was named as the Women's Health Initiative Study, WHI. The first report, the premature report, came out in 2002, actually. And as a consequence of that, the prescription pattern for hormone replacement therapy went down significantly in the US and around the globe as well. And so I started following the literature very, very closely. At the same time, I started my own research looking at estradiol levels in women and their relationship with metabolic markers and progression of atherosclerosis, which is the thickening of the arteries. That's the primary reason why people suffer from cardiovascular disease. So my research showed that higher levels of estradiol level in women were beneficial in terms of reducing the progression of atherosclerosis or thickening of the arterial walls. However, the clinical trial reports from WHI indicated otherwise, and the health effects actually were involving blood clots and stroke, completely different pathology. Anyway, so there were subsequent studies coming out of WHI looking at different formulation of the hormones. The initial report, that study included progesterone and estradiol regimen, which is called combined therapy. And subsequently, they they published another report from the same study, but this time the women were randomized to estradiol alone versus placebo. And that showed no effect, no adverse effect, no adverse cardiovascular effect, meaning no benefit either, but no adverse effect either. So that point on, a lot of analysis of WHI data has happened, and eventually what we learn now is it depends a lot on when the women are initiating the hormone therapy. It has to be soon after they start experiencing menopause, perimenopause, or early postmenopause. And that took another 4 or 5 years of analysis to understand. So for all of these, I was heavily involved with this research, and subsequently had published many articles on this area. So this is the story of inspiration for my work involving menopause and menopause-associated health outcomes. So bone loss is one of the major adverse health effects of menopause, and just frankly speaking, estradiol is the only treatment for prevention of bone loss, and that has been shown in many research. No alternative works as good as estradiol. And I also actually published an important work on this, where I looked at about 80,000 postmenopausal women who were receiving health care at the Kaiser Permanente facility, HMO. And I looked at their hormone replacement therapy health record within the Kaiser database, EMR, electronic medical record, going back to 2002. So I followed all those women who were on hormone therapy in 2002, and then followed them up for an average 6 years, and tracked their record of hormone therapy intake. And a lot of women, substantial number of women, came out of hormone therapy post 2002. So I also looked at the changes in their bone density, bone mineral density, or BMD, over those 6 years, side by side, their usage of hormone therapy or not, and showed a significant, decrease in their bone mineral density with stopping the hormone therapy over the 6 years. So that paper actually got a lot of attention, a lot of media coverage and press, and eventually was included within the U.S. Task Force for Clinical Practice of Women's Health and Hormone Therapy Usage. The third outcome that's also very important, which is cognitive decline. And on this area, the evidence is not as clear as osteoporosis, effect of estradiol on osteoporosis, but we are still, from the clinical trial, the data that I have used for most of my work, early versus late intervention with estradiol, ELITE trial. And that study, we also didn't find any beneficial effect of estradiol therapy in postmenopausal women for their cognitive decline. There was no benefit of that. So we are looking more and more into this, and there have been some recent developments from other groups who are showing that that it might help, and then others are showing no results. So we are still trying to sort this out. Who are the ones who benefit from estradiol therapy and who don't? There has been tremendous change in practice of women's health back in Bangladesh. And I have been in touch. I actually initiated some new public health research in Bangladesh recently, but I have been in touch with their clinical practice and everything, and I go give talks over there. Yes, hormone therapy has been included within the clinical practice of women's health for years now. I would say early early 2000 or late 2000, that's when it started becoming popular, and clinicians also started prescribing. We definitely need more research involving the effect of estradiol therapy on cognitive decline. So far, it has been tested in many studies, and the results are mixed. So we definitely need to look at this more closely and identify the high risk women who will benefit from estradiol therapy, because there is indication that estradiol should help with cognitive skills. However, we haven't been able to see this consistently across different research that is available at the moment. As a matter of fact, the damage that has been done by the initial WHI reports and the population, it was never really clarified with force, so it is well disseminated. That hasn't happened yet, I'll be honest with you. However, things come with its own evidence. No matter how much you believe in something, you need to have enough evidence to support your statement. Now the evidence is there, but still it is not being disseminated as it should be. So I don't think we have done enough to remove the false perception or misperception about hormone therapy. And then on that regard, I'll mention one other health outcome that has been linked with hormone therapy, that is breast cancer. Initial days there were, it was perceived as it's going to increase the risk of breast cancer as well. Interestingly, it did with the combination therapy. However, the WHI estradiol alone arm, that part of the trial, it clearly showed no association, if anything, in its benefit. But those things are not being promoted as strongly as it should be. So definitely there are misconception about hormone therapy in women community, including practitioners.
Preventive Pros, the podcast, is produced by the Department of Population and Public Health Sciences at Keck School of Medicine of USC. To learn more about any of our episodes, or to subscribe to our monthly Preventive Dose newsletter featuring the latest in public health research and news, visit pphs.usc.edu/podcast. Thank you for listening.